Hi, I'm Dr. Gil Wilshire. I'm a board-certified physician, surgeon, and reproductive endocrinologist. Welcome to my series of podcasts where we discuss medical matters that matter to you. I'll be interviewing top experts in their fields, and we'll also be delving into fascinating backstories from deep within the world of medicine. Welcome to the Dr. Gil Show. This is the show where we talk about medical matters that matter to you. Our guest today is Dr. Johnny Adams. Welcome to the show, Johnny.
Well, thank you very much. It's great to be here, Gil.
I've been really looking forward to having you on the show. Dr. Adams is a medical doctor, he's a surgeon, and he is a specialist in vascular surgery. And today we're going to talk about vascular surgery and all the incredible things that you do.
Well, I've been so fortunate in my personal and professional life of having great mentorship around me. And one of the guys that shaped me in my professional career, maybe as much as anybody, was a guy named Walter Peters.
Walter, general
Yes.
surgery, colorectal. He's now down in Dallas, I believe.
Yes, he's
Great
part
guy.
of the Baylor healthcare system in Texas.
He went the other way.
Huge system.
Yeah.
And so Walter got an MBA. He was the president of our group, Columbia Surgical Associates, shortly after I got here, and remained the president until leaving, I think, in 2016. Maybe he left in 16 or 17.
About then.
And so he had gotten an MBA, and he said, "Hey, you should think about this because there's just so much about the business of healthcare and the business of our group that you don't know what you don't know."
Right.
Until you know. And he was absolutely right. And so I did. I went back to the University of Missouri. I got an MBA, 15 to 17. Yeah. And it was just such an eye-opening experience. And it was another bit of knowledge, a fund of knowledge to try to master and so forth. Not that you would ever master that, but it was certainly something that I had not delved into before, and really was exciting, and it continues to be. After Paul Humphrey retired, then I became the president of our group in 2018, and have been the president since then. So, It's something that I think is it's almost a necessity in today's healthcare environment if you're going to lead a group or be part of a big system, etc.
Right, that makes a lot of sense. So those are skills that you're really using now. Let's finally get to vascular surgery. And just for my general audience, vascular means vessels. And vessels come in different types. There's the arteries that come out of the heart, high pressure, thick-walled. They have their own issues. And that's what feeds our body. Then you have the veins that come back. This is a low-pressure system. All the pressure is used to push the blood through our organs and our tissues, and then it kind of trickles back in the veins. They're thin and have their own issues. And then there's lymphatic vessels that also kind of, these little wispy vessels that kind of come back with the veins, and we may talk about them a little bit. But the blood vessels are clearly crucial for life, and there's a lot of things that can go wrong with them. Now, there's a lot of things you do, and I was thinking, how am I going to address this? And I found a simple way to address this, Johnny. We're going to start at the feet, and we're going to work our way up through the body.
Okay.
Now, I as a busy surgeon like you, I have these compression hose on my feet here because my feet are starting to swell at the end of the day as I get older. What's going on with that?
Well, you have a very common condition, and in fact, more than 50% of people over the age of 50 and roughly 70% of people over the age of 70 have a condition called venous insufficiency. And so that's what's going on. And basically what is happening is, just as you alluded to, those low-pressure veins, the low-pressure system in the body, when we stand erect all day, we're putting an incredible amount of pressure on those veins, and the blood tends to pool in our lower extremities. From a teleological standpoint, our lower extremity venous system was not made for us to be upright as much as we're upright.
Gotcha.
And so we have these little bitty valves in the veins that we depend upon a great deal to push the blood or propel the blood toward the heart. And over years and years of that pressure, they tend to wear out. And so when you get into your 50s and 60s and 70s, it's not uncommon for us to see those valves wearing out and the blood pooling, and that causes the swelling. It causes the fluid in the tissues, and that's why at the end of the day your feet swell.
Mm-hmm.
When you go to bed at night and you resume a recumbent position, then when you wake up the next morning, most of the time all of your swelling is gone. Now, your compression hose actually are like an exoskeleton compressing the tissues, and they tend to keep blood from pooling. They tend to keep fluid from accumulating in your tissues. And so we do prescribe an awful lot of compression hose. And actually, I wear compression hose, having turned 60 recently. I'm actually 61, and so I wear those hopefully to head off any issues that I might have with the venous system. But you're talking about the venous system.
The venous system. So if we're getting a little older, we've got some swelling, compression hose is a very practical thing that almost anybody can do. And as long as it's not cutting off circulation, why not, right? And I found the good ones cost more. You get what you pay for.
Exactly, that's exactly
with compression hose.
They come in a lot of different levels, and so we do prescribe different levels. For most people, a level 1 or 2 is very sufficient.
Gotcha. These are actually rated in millibars. There's like 20 to 30. I don't know what the units is, but it's actually has a rating on these.
That's exactly right. So up to 15 to 20 millimeters of mercury.
That's what it
is a 1, compression level 1, and then 15 to 20, 15 to 25 is usually a 2, and then above 30 or so is usually what we would rate as a 3. Now the 3s are for people with severe problems. And when I say severe problems, I mean chronic swelling of the limb, skin changes associated with that, hemosiderosis, which is a darkening.
What is that? It's a darkening?
It's a darkening of the skin. And in fact, what happens is you accumulate fluid in your tissues, you're going to accumulate some red blood cells in there as well. And remember that the heme molecule has iron in it. And so when you break down the iron molecule, it's a brownish discoloration. And that's called hemosiderosis. It's a brownish staining of the skins. And the other thing that happens with this whole process is that in the subcutaneous tissues, you get this inflammatory process that takes place. And if you palpate the tissues of the leg of someone who's having this accumulation of fluid and scarring process, it will feel very abnormal to you. It's not the nice, soft tissues that you're used to feeling.
A firmness or something?
Very firm, sometimes associated with even a redness in the acute phases, and then, as we've said, this brownish discoloration. So some people describe that as almost the feeling of a hide.
Like a leathery
sensation,
feeling.
yes.
So if somebody notices that might be something to go to you about. Now, there are other things in life that'll make this even worse, and sometimes the veins will start swelling, and you'll start seeing those little snakes and ropes and worms, those purple worms under the skin.
Yes, varicose veins.
Varicose veins. Now, having delivered a number of babies in my training, I saw that pregnancy clearly increases the risk of these veins developing and swelling up.
Absolutely. And you know better than I do that a lot of changes during pregnancy can lead to this. And in fact, often do lead to this. And those changes we're talking about are the increase in the intravascular volume, the increase volume, and the pressure of the lower extremity venous system by the uterus pressing on the venous return.
Which is on the brim, on
the
groin here, and compresses these veins. They back up and they get swollen. So when should, and it's mainly women, but men can have this too, I assume.
Absolutely. And the reason women during pregnancy are so predisposed to this is by the increase in estrogens and progesterones during pregnancy, which exerts a deleterious effect on the lower extremity venous system in and of itself.
Gotcha. So let's say, I guess usually a woman, but could he be anybody, is starting to notice these veins, these purple curly veins coming up. When should this person go to a vascular doctor such as you for evaluation?
Well, I think the one thing that that I would tell all pregnant individuals is during pregnancy, it's probably a great idea to wear compression stockings, and the higher the better. Now, a lot of people prefer the knee high. They come in knee high, thigh high, and even pantyhose varieties. But really, the pantyhose are the best.
It goes all
If
the way
you
up, and you don't have a
all the wa-
line. You don't have a
yes,
constricting top.
and they don't fall down, and they're
Ah.
easier to wear, and they do a better job of compressing the entire venous system up through the groin area. And so, if you can tolerate that, that's best. As far as developing varicose veins in pregnancy, there is a familial component to that, and usually mom or aunts have had a similar problem during pregnancy, and so that's important. That certainly may mean that you're more predisposed to the development of varicose veins than other women who have not had mom or aunts that have developed this.
Okay.
And so, as far as coming to see a vascular specialist about your varicose veins, I think first and foremost, I would tell people who are interested in having more children that number one, after pregnancy, after your estrogen and your progesterone levels subside, and after you get rid of that excess fluid, and of course, obviously, you don't have the fetus pressing on your venous system, a lot of those varicose veins will actually recede.
Really?
Yes. And so you want to give it a little bit of time for them to recede. And if you're interested in having more children, then certainly, unless there's a complication of a varicose vein, like a thrombus,
What is a thrombus in plain English?
it's where you develop a little blood clot
A
within
clot.
the varicose vein.
Now,
Which
can a patient feel that? Will it get hard? Will it go from soft to hard?
actually, yes. And that's called superficial thrombophlebitis when the blood clots occur in the superficial venous system.
Okay.
Now, that's to be distinguished from a blood clot that occurs in the deep venous system, like the femoral vein or the popliteal vein or one of the tibial veins.
These are the veins kind of behind the knee, deep that you can't necessarily feel.
Yes, that
Okay.
is correct. And in fact, the deep venous system carries 90% of the blood from your tissues of the lower limbs back up to your heart. So they're extremely important. And when you develop a blood clot in a deep vein, it's usually associated with swelling of the leg, unilateral swelling, as
So
a
on
matter
one
of fact.
side.
On one side, sometimes pain, that's plus minus, not always, but swelling is kind of the hallmark. And a venous ultrasound or a venous duplex examination is the test that we use to diagnose that. The reason it's so important to diagnose that and to treat that is because deep venous thrombosis, or DVT as it's known, can embolize or move.
And these kill a lot of people.
The blood clot can break off and go to the heart of the lung, and it really is something that's an urgent type situation that really needs to be treated.
Gotcha.
So yes, but the superficial thrombophlebitis is where you have the same situation, but it's in a superficial vein. For all practical purposes, they don't break off. They don't go anywhere. Now, can they? Yes, anything is possible. They can.
So it's more of a cosmetic issue. So let's say a woman in this case has these veins developing, usually on the inside of the knee and the inside of the thigh. As long as they're not hurting and they're soft, and you can live with it, you don't have to do anything. Is what you're telling me?
That's correct. You don't have to do anything. After you're finished having children, and again, we're talking about someone who's not had any complications, then certainly a vascular specialist, a vein specialist is a person who you would want to see. And they're probably going to want to do an ultrasound to see the extent of your venous abnormalities. And then based upon that, discuss treatment options with
Now,
you.
is this something you treat?
Sure, absolutely.
So
We do a lot.
it's my understanding that the big vein, the culprit, is usually called the saphenous vein. Is that right?
That is correct.
And I believe you can go in the saphenous vein and block it. You can go in there, do some endovascular magic, and block that vein so it stops backing up and that vein shrinks down. Is that
Yes,
correct?
that is exactly correct. You've done your homework very well, Gil.
I do a little bit. I've done a little bit of reading before I interview you.
You know way more than you're letting on. But you're exactly right. You're
So
exactly right.
how do you go in there and block that vein? I've heard of lasers and radio frequency and
Yes.
sclerosing foams and whatnot. And
Yes.
How do you do that?
Actually, you can do that with any of the modalities you just mentioned. The most common modality is using a laser to actually block off the great or the small saphenous vein in the setting of that vein not working correctly. So we have a vein, the valves are not working correctly. We have what we call reflux, which is where rather than the valves propelling the blood toward the heart, the valves are not doing their job and the blood is falling back down into the lower limb and it's pooling there, as we talked about earlier. And so in that circumstance, we want to reroute blood through veins that are functioning well. And so if we have someone that just has, let's say, an insufficient great saphenous vein, then we would go in with the laser or with radiofrequency and sometimes with foam and actually block off that vein completely, which would cure the patient of the reflux they're having down that vein and reroute the blood, which the body will do automatically.
It'll find. I was going to ask you, how does it come back? It just finds another route because they're all interconnected.
Yes, it actually goes through a different pathway. And I actually might point out that that's a pretty recent development. It's a pretty recent procedure for vascular. And I would also point out that it's been deemed the second most significant improvement in vascular surgery in the last 100 years.
Saphenous vein occlusion.
Yes, saphenous vein ablation, we call it.
Ablation.
Yes. So great saphenous or small saphenous vein ablation. You can also do the same thing to accessory saphenous veins and some of the other longer, straighter, varicose branches thereof of the great saphenous vein or the small saphenous vein.
So you can really, there is hope for people, these big veins, and you can help them pretty straightforwardly.
And not only is it a very successful procedure with a 5-year success rate of in excess of 95%, but it's a walk-in, walk-out procedure. And we do probably 98% of these without an IV, without any sedation. Well, I take that back. Actually, we do give patients a pill the morning of, like an Ativan 1 or 2 milligram pill to take the edge off. But no IV sedation, walk in, walk out. And literally they can resume their normal activities within 48 to 72 hours.
Amazing.
Some people are more aggressive than that, actually. So that's usually our scenario for postoperative care, 48 to 72 hours.
And if it is a woman, you should do that after you've had your babies.
Yeah.
Like tummy tucks.
Yes.
Like people get the tummy tuck and have another baby. Bad, wrong order.
Not a great idea. So yes, we usually treat their varicose veins after they're finished having children and so forth. But I want to say one other thing, and that is that we're doing this mainly for functional venous problems. Now we do cosmetic venous problems as well. So
what do you mean by functional?
Okay, so functional is where you're having swelling or you're having phlebitic pain, which is where you have legs that are burning, stinging, aching the longer you stand on them. Or you've had an episode of superficial thrombophlebitis, or you have a little ulceration over a vein, or you're having skin changes.
Is starting to break down,
yes,
a little bit.
So those are all
not pretty.
Those are all functional problems that we treat. We also will have patients who come in and say, you know, I really don't have any of those things. I don't have any burning, stinging, aching legs in the evening. I don't have any swelling. I just don't like the way my legs look. And okay. I've got this ropey vein on the back of my right calf, and it's about 8 inches, and I've had it since I was a cheerleader, and I just don't like it, and I want to get rid of it. Okay, yeah.
You can fix that.
We can do that. And so we do cosmetic. We call that cosmetic, and so we do a lot of cosmetic work as well.
And you can fix it.
Sure.
Now let's take this same leg. We're maybe getting older. Now it's getting pale and cold. And maybe this person has smoked a couple cigarettes or has had blood sugar problems in their life, and the legs starting to get achy and cold, and it doesn't seem to. Maybe it's getting a little weaker. Uh, what might that indicate?
Well, Gil, you're now moving into the arena of the majority of what we do, actually.
All right, excellent, good segue.
And that is peripheral arterial disease. And it turns out that the arteries in our body, which take the blood flow from our heart out to our tissues and organs, as you previously mentioned, are thicker and are prone, way more prone, in fact, maybe prone 100 times more than the veins to buildup of plaque. Blockages, that's exactly right. And so these arteries are prone to develop problems with blockages, with aneurysm degeneration or formation, and things like that. And as you also mentioned, the aging process predisposes us to that. Nicotine predisposes us to that. Diabetes,
high blood pressure,
hypertension, high cholesterol levels, lack of a regular exercise program, hereditary components. So there are a lot of things that are risk factors for that. And interestingly, in this country, atherosclerosis is almost endemic. And it has to do with our diet, it has to do with our genetics, it has to do with our lack of regular exercise. And if you look at young individuals who are in car wrecks, who die in car wrecks, and who get autopsies, you will find the early formation of plaque in arteries in individuals who are 17 and 18 years old. So it's the beginning of that whole process. And if you went to a country like China 30 to 40, 50 years ago, you would not see that even in individuals who are older. And the reason it was because their diet, very low in cholesterol. They exercise.
Well, I don't want to get too much into cholesterol because I think most of that is bullshit. But I will leave that. And I think there's a lot worse risk factors for vessels.
Well, everything in moderation. There's no question about that.
And I'm going to have whole podcasts on this subject, so I want to avoid that rabbit hole.
Okay.
But so, let's just say refined foods, Western behaviors, patterns are creating this.
My point is that if you visited China 50 years ago, atherosclerosis was a non-entity.
Wow.
If you visit China now, it's huge. And the reason it's huge is because they want to be westernized.
They have the Western
They want
diet.
to drive a car. They want to eat our diet. They want to smoke cigarettes. I mean, they want to do all the things that we do, and hence the.
So it's something in there.
Yeah,
right?
so
we can argue about it, but we
I'll,
can say the bird's eye view here.
Yeah.
It's the whole thing is creating these vascular diseases and blockages. So a person is getting a blockage.
Yes.
Legs getting cold. What can you do to help this person?
Well, when someone develops a blockage, usually
and sometimes it's slow too. I mean, it's a partial block. It's not all of a sudden.
It's almost always slow. Okay. Now there are some acute syndromes where you have acute blockage of a blood vessel resulting in an acute problem with the end organ, the limb, etc. But mainly we're talking about a chronic, slow process. And one of the first manifestations that as an individual you would experience would be intolerance to exercise.
And is weak or they cramp?
Yes. So this almost always occurs in the lower extremities as opposed to the upper extremities.
I'm glad we started in the lower extremities.
Yeah. As a matter of fact, the femoral artery is the most commonly involved. The superficial femoral artery down just above the knee. At what we call the adductor hiatus, which is an anatomic differentiation between the superficial femoral artery and the popliteal artery. And there's something about that area, and this is debatable, and we're not going to get into that, but there's something about that area that causes plaque formation. And so that's the most frequent area involved. And when that's involved and you decrease the blood flow significantly, you're decreasing the blood flow to the calf. And so frequently the first manifestation is that someone who could go out and get their mail at their mailbox, say 500 feet from their house, is no longer able to get back to the house in one trip.
It's
They
usually
have
one side. It's kind of a hint that maybe it's one side.
yes, for
Ah,
reasons that are unclear, it's usually
right.
one side.
It's not going to be equal on both legs
It
every time.
it can be, but it's not
Right.
typically. And so they come in and they say, "Hey, I'm having a cramp in my leg. When I walk, when I stop and rest, it goes away, and then I'm able to walk again for another, say, 300 to 500 feet." And so that's kind of the first tip off. Now, you said a cool foot or leg. And yes, that does happen, but it's usually as things progress that you get. You go from what I just described as claudication being exercise induced cramping of the musculature,
Okay.
to rest pain. And rest
Then it's getting
pain
bad.
is when you go to bed at night, you elevate your leg, you don't have gravity help you with the blood flow down to your feet, and now all of a sudden you start getting pain in the leg or the foot because you don't have that gravity to help, and that's called rest pain. And basically what happens is your tissues cannot get enough blood to satisfy their basic metabolic demands. And that's a bad. In fact, we differentiate to a large degree claudication from rest pain. Claudication carries a less than 1% risk of limb loss per year. Rest pain, on the other hand, is about 25%.
So this
per
is
year.
high stakes. You could lose a limb.
Yes.
So someone comes to you, now they've got rest pain,
Yes.
Johnny, and you do whatever studies you do, you find that there's some blockage in there. Now, what can you do about that blockage? Can you open it up, or what can you do?
Before
that.
I address that and go to what I would consider to be the exciting part of this, let me tell you some boring stuff. And the boring stuff is that when we see patients with claudication, and we see a ton of those patients on a weekly basis, it's a conservative management program. And what I mean by that is we try to correct as many risk factors as we can. Now,
Quit smoking, lose weight,
yes,
increase
all
your
those
activity
things,
a little
all those
bit. Or
things.
okay.
And our success rate with that is abysmal. I'm
Right,
just going
right.
to tell you, it's
I want a
terrible.
pill. I want a
Because
pill.
you take a patient who is in a certain culture, lifestyle, grown up for the last 50 years doing things the way they want to do them, and now you tell them that, hey, all this stuff that you've been accustomed to doing, we want you to radically change it. All their friends do it.
Yeah,
Their
it's not going to
coworkers
happen.
do it. It's probably not going to happen, as you said.
Not often.
So then when we see people with rest pain, then we know, okay, we got to do something here. If we don't intervene, then we're going to lose a toe or a foot or a leg.
Yeah.
And unfortunately, that does happen. And so intervening, you can divide into two big groups: open interventions, which is what we've done for years and years in vascular surgery. And what I'm alluding to are cleaning out blockages, bypassing blockages. They're the two most common ways that we have to deal with blockages for an open intervention. Or we can do an endovascular intervention. And an endovascular intervention means that we basically can clear the blockage by stenting, or by sucking the blockage out. And I'm using some
do that,
terms
huh?
that I think your audience would understand.
Yeah.
We don't technically suck the blockage out. We can use a little roto-rooter and suck out the little particles.
So you've
and
got a
stuff.
roto-rooter
Yes.
that can open that up potentially.
Yes.
Do you ever use those balloons like they do in the heart to push them open?
Absolutely.
And stent. Now a stent is one of these little wire cages, all compressed, and it springs open.
Yes.
You can put stents in a leg.
Absolutely. So the balloon is called angioplasty, a percutaneous transluminal angioplasty. We can do that through a catheter, and the catheter is about the size of the end of a ballpoint pen. And basically, we introduce a balloon across the blockage. We push the blockage to the side. And mature blockages that we're talking about have usually very little recoil, so we're pretty successful at doing that.
You crack them
It
open.
turns out, yes, and it turns out that some arteries are really good at percutaneous interventions, and when I say good, I mean the 5-year risk of them developing another blockage there or reaccumulating the blockage in the same place is low. And other arteries are just terrible. We just don't do very well at using balloons.
They're just different.
And so, another way to help obviate that low success rate is by putting stents in, which are little wire mesh cages, if you will, to hold the artery open. And again, that works really well in some arteries and doesn't work worth a damn in other arteries.
And that's where you need an experienced surgeon who knows the difference. Now, let's say it's getting really blocked, Johnny, or completely blocked, and now blood is finding other ways around. Blood's trying to go out the little arteries, and they're all damaged and whatnot. Do you do something like an actual bypass of these blockages?
Absolutely.
Would you describe that for me, please?
Okay, so a bypass is really a plumbing problem. I mean, I hate to say it like that, but it really is.
For us to understand.
So let's say that you have a pipe that's completely blocked off. You need good inflow and you need good outflow, and then you need a good conduit around that. And so if you had a pipe in your house that was blocked off and you couldn't access it, or you knew that accessing it and cleaning it out was really not very good, you wanted to bypass it, you would put a piece of pipe from good inflow around the blockage to good outflow. And you would probably tie it in and do it all with a really good conduit, another pipe of the same size or even a little bigger. And that's exactly what we do in vascular surgery. The conduit that we love to use is the patient's vein, the patient's lower extremity saphenous vein. A nice saphenous vein without any blood clots in it of sufficient size is the best conduit that we have for bypass, bar none.
So you'd cut it out, you would move it, you'd graft it from one part of the leg, get a good piece of saphenous vein, and transplant it.
Yes, that's exactly what we do.
And the vein will hold the pressure of the artery?
Yes, it will. Yes, it will. And in fact, the saphenous vein, and we're talking about a good saphenous vein that's not varicose. It doesn't have any blood clots in it.
You haven't been in there with lasers and radio frequency, right?
And in fact, that's a question a lot of people ask me. A lot of young people with varicose veins say, "Well, my saphenous vein, what if I were to need it like Uncle Joe did at the age of 60?" And I say, well, your saphenous vein is not of good quality. That's the reason that we're going to laser it, and it wouldn't be of good quality to use for a bypass anyway.
Okay.
But yes, we use the saphenous vein for the bypass. The thought that people had many, many, many years ago that, well, it's thin-walled, it's going to be subjected to pressures much higher than it's used to seeing. Is it going to become larger, dilated, aneurysmal?
Okay.
The answer to that is no. It usually does not. It almost never does. Now, if you have one that's been in place for 20 or 25 years, I've certainly seen aneurysms develop in those. But we're unfortunately, when patients come to us with major blockages, I'm gonna tell you that their 5-year survival from their heart problems and their lung problems and their kidney problems and all the other things that are usually going on with them means that the 5-year survival is about 50 to 60%. And that's pretty harsh to say. And I'm going to say something that's pretty harsh, which is we're not looking for a solution for 20 years. We're looking for a solution for 5 to 10 years.
Because whatever is affecting this blood vessel is probably affecting blood vessels elsewhere at the vital organs.
And I know you had Dr. Fernandez on recently, and I'm sure that he alluded to that because it is a very common problem where atherosclerosis not only affects blood vessels in the periphery, but it also affects those heart blood vessels centrally that are so important, blood vessels in our brain that subject us to stroke, etc.
Gotcha. Now, if you don't have a saphenous vein, do you have any synthetic tubes and conduits that you can use, and what are they called?
Well, we do. If we didn't have a good saphenous vein, the next best thing, and this is again debatable. I mean, everything in vascular surgery, I think, is debatable. The only thing that isn't debatable is a guy named DeBakey.
And death and taxes.
If you say, what's the name of that instrument for vascular surgery? chances are you're going to be right if you just
It's
say
a
debakey.
debakey.
It's a debakey. Okay, it's some kind of
In
debakey.
gynecology, it's a Sims. Everything's a Sims.
Yes,
Yeah,
there you go.
yeah.
So, so the next best thing is either cryovein, which is vein that's been taken out of a human cadaver and prepared in a
they
special
have these
way.
things.
Yes.
You can have cadaveric vein. I didn't know that.
Yes, and we typically use cadaveric vein when we're dealing with infection. And
it's not a foreign body.
It's not. That's exactly
I
right.
love it.
That's
Love
exactly
it.
right. And so it does tend to do maybe a little bit better in tissues that harbor infection versus those that don't harbor infection. The other thing that we use a whole lot of is synthetic vein, if you will, or a very fancy Teflon called PTFE, which stands for polytetrafluoroethylene. And PTFE is something we've been using for over 40 years now, probably almost 50 years. And PTFE basically is a synthetic mesh that we use as a conduit for the blood.
Is that what they make nonstick pans out of?
Teflon. It's a fancy Teflon polymer. Yes, it is.
So you can get a synthetic too. So if they don't have a saphenous vein, you can put these two. You can bypass blockages.
Yes.
All around the body.
Yes, and one of the more innovative things that have been done with PTFE recently is that there's an there's a graft you can get that has an inner lining of heparin, which is a very potent anticoagulant to keep the blood from sticking to the walls of the PTFE and hopefully keeping it open longer. So obviously it's not as good as saphenous vein. Saphenous vein is by far the best if you have a great saphenous vein, but if you don't, then a lot of people use either cryo or PTFE. And I have to be honest with you, PTFE is one of those off-the-shelf things that is pretty easy to use. So it's a wonderful alternative if you don't have a good saphenous vein.
Yes. So in summary, there's these areas that tend to block.
Yeah.
And these areas that you frequently will bypass. And when I tease the vascular surgeons, we've got femoral and popliteal and iliac, and they shorten it as fem and pop. So I say, hey, you're doing a pop fem pop or a pop fem pop today.
I've only heard you say that about 50 times.
I love it. I love it. That's shorthand that vascular surgeons use to. Right. So you're doing that quite frequently, and you're helping a lot of people. Now, the artery's closed off. The limb is starting to get infected, turns black, gangrene. Sometimes you have to amputate a limb, don't you?
We do. Unfortunately, we have patients who come in and they have a limb that's beyond salvage, or an infection that means the limb is beyond salvage. And so, there are times we have to do that. Or there are also those patients who, I've had patients in my practice and now children of patients in my practice, and actually even some grandchildren.
Oh, well, we're getting old, Johnny.
And so, there is a genetic component, et cetera. And so there are patients who we've been working on for a lot of years. And we kind of come to the end of the line of what we're able to do.
And people don't. I didn't realize till I was in medical school that vascular surgeons do a lot of the amputations. It's a part of your job that people might not realize.
We do, and actually we do that because of the relationship that we have with the patient. Now, this is one of the things that really drew me to vascular surgery, and that is we do the operation. We then follow the patient from then on. And the reason we do that is because we know that if we do certain surveillance with appointments, evaluations in the form of examinations, and non-invasive vascular testing, that we can pick up problems of the operation that we have done before they would lead to a major problem or even an amputation. And so not infrequently we'll do an operation on a patient, and for the next 20 years we'll follow that patient. Wow. We're limited sometimes, obviously, by the patient's longevity, but we do follow patients from that point onward. So we have a relationship with them, and if we reach a point where they're going to lose a toe or a foot or a limb, then we frequently do that because of the relationship and the trust they have in us, and obviously the trust we have in them.
Yeah, and that's why the training in general surgery is so important. You have to be a surgeon first, vascular specialist within that field. So working our way up the body, John, there's this big blood vessel that comes off the heart called the aorta. And comes up and feeds the upper body and goes down, feeds the kidneys and the bowels. And that artery can sometimes swell and because it becomes something called an aneurysm. And we both graduated from medical school the same year. We both have seen amazing advances in our respective fields. Just amazing. We're in a different world nowadays, what we can do now versus what we had to do. And I know when one of these aneurysms gets real big and starts to explode, it's called a AAA, an abdominal aortic aneurysm. And I will never forget when I was a medical student, having somebody with these purple bruises on the belly and a backache and an x-ray, and the surgeon said, this is a rupturing aneurysm. I remember being the assistant. They used to open the belly all the way, and if it was bursting, the blood would be just pouring out. I remember them putting the clamp on the aorta, and I would hold the clamp, and I'm feeling it pulsating as they would cut out this swollen aorta and put in a graft, one of these artificial fiber grafts. And a lot of people would die, and it was a very bloody procedure, and it was risky, and it was a lot of drama and whatnot. But I understand that you now can do something much more elegant for something that's life-threatening and enormous, such as a AAA. So would you tell us, what can you do about these aortic aneurysms that we could not do when we were medical students?
Well, as a matter of fact, abdominal aortic aneurysms are one of the more common aneurysms that we see in our patient population in their 6th, 7th, and 8th decades of life. And these aneurysms develop, we used to think that they developed from and they do, from a degenerative process, but we kind of had it wrong. It turns out that these aneurysms are familial in some cases, related to nicotine in a lot of cases, and related to some different enzyme deficiencies, if you will, in the wall of the artery.
So it runs in families, and there's a metabolic component. So
yes.
So you definitely could have a tendency or propensity to make one of these.
Exactly.
Interesting.
And in fact, if you did an abdominal aortic ultrasound of everyone's abdominal aorta over the age of, say, 65 to 70, you'd probably find an aneurysm in 2%, 3% of people.
A significant one, like a life-threatening one, like it could go.
No. You would find just an aneurysm. And an aneurysm is defined as 1.5 times the normal diameter of an artery. So the abdominal aorta is typically in a man somewhere around 16 to 20 millimeters in diameter.
Okay.
And so you'd find an aneurysm of 30 millimeters or higher in that percentage of patients. And you would find a significant aneurysm if you coned it down to where you're just screening people who smoke. Then you would find more significant aneurysms than if you just screen the population at large.
And
what I'm getting to is it's not an insignificant finding. Now, we don't fix these aneurysms until they get large enough to burst. And what size is that? Well, it's about 55 millimeters.
Wow.
And so we watch an awful lot of them from, say, 30 to 35 all the way up to 55. And then we start repairing them at 55 because we know that's the size that the risk of the operation is less than the risk of rupture. It's about 55 millimeters for most people.
Gotcha. So what are these amazing things you can do now so you can avoid these enormous, bloody, risky operations?
In fact, it's been deemed the most significant advance in vascular surgery in the last 100 years, the endovascular repair of an abdominal aortic aneurysm. And the thing that basically is done is that you go through the groin arteries or the femoral arteries down in the groin area, and under X-ray, you're able to put covered stents inside the aneurysm.
So you're not opening the belly at
That's
all.
right.
First of all, a lot of these cases, you're threading a tube in through the groin, and through that tube, you have a device that goes in and expands and essentially relines the aorta. Is that what's
Yes,
happening?
it redirects the blood flow from the walls of the aneurysm. So it takes the pressure of the blood off of the wall of the aneurysm and now exerts the pressure inside the covered stent so that you don't get that pressure, that bursting pressure, if you will, of the aneurysm wall. And if you don't have that bursting pressure, then typically the aneurysm sac will shrivel down around the stent.
The new inner
And it's
tube.
amazing.
I
It's
love it.
amazing. So
I
we
love
started doing those in 1999 at Boone Hospital. A retired partner of mine now named Kurt Vogel, Paul Humphrey, and myself. And in 1999, we started doing these things. And believe it or not, I still have a couple of patients from 1999 who we follow once a year, do an ultrasound just to make sure that the endograft, as we call it, the covered stents, looks good and that we don't have any problems associated with that.
And they're still
It is
alive.
amazing. And let me just say this.
Please.
When you and I were in training, those patients you're talking about would be in the hospital anywhere from minimum of a week all the way out to 2-3 weeks.
Yeah, long
And that's
time.
if things went pretty darn good.
Yeah, without a major complication.
Yes. And the risk profile was 15 to 20% for heart attack, stroke, kidney failure. I mean, all kind of, if you name it, it could happen with an aneurysm. Nowadays, with our endovascular repairs, the risk profile is somewhere around 3 to 4% all for everything.
Wow.
And the major risks are about 1% or less. And almost everybody goes home the next day.
That's
It is
fantastic.
absolutely amazing.
Wow.
And I'm still, what is this? This is 24 years later almost, 23 years later. I'm still amazed at that we can do that. It just revolutionized the treatment of aneurysm. It really did.
Yeah. Now, what if an aneurysm is bursting? Can you still do that?
You can. And there are a number of studies to show that if you treat a ruptured aneurysm with endovascular techniques, if you can, we can't treat all of them with endovascular techniques. I would say 80 to 90% we can. There are still some that we cannot. But if you can treat it with an endovascular technique, the chance of survival is much better than if you have to go in and do an open repair like you alluded to earlier.
Wow. So here's a personal question. When was the last time you did an open aorta?
Well, we still
aorta.
do elective open aortas. The last time I did an elective aortic repair was probably within the last month.
Last month. So you still do them.
We still do those.
You're not getting rusty.
I don't. Well,
Not that any surgeon would ever admit that.
I hope not. We don't do as many open things as we used to, but we still do a lot of open stuff. Now, I do a lot of exposures for spine surgery, and when we do that, we do move a lot of the big veins and the arteries, namely the abdominal aorta and the inferior vena cava and stuff around. So we still do a lot of open stuff, just not aneurysm repairs.
Yeah, so you're not rusty in the least. Yeah, a lot of people don't realize that the orthopedic surgeons that need to get to the back, and we had Dr. Miles here earlier, will sometimes need a little assistance because these are big veins, big arteries, and they can bleed. They can be so getting exposure of the spine is crucial, and that's where you and your colleagues will help do that.
Absolutely. And it turns out that one of the better ways to address the lumbar spine issues that the spine surgeons deal with is from the very front. And to get to the spine from the very front, you have to, at the L5-S1 level, and really at all of the lumbar levels, you have to move the aorta off of the lumbar spine and the vena cava off. And so vascular surgeons, by and large, are the ones that do that. There are other surgeons that do that, but someone very facile with open techniques and handling blood vessels is the person to do that.
So, moving on, let's move our way up the body. Sometimes the blood vessels from the aorta to the kidneys or the bowel will get partially blocked.
Yes.
I read something about a nutcracker where the vein for the kidney is in the wrong. And I think my cadaver as a medical student had a nutcracker because it screwed up my understanding of anatomy because the vein was in the wrong place in my cadaver. Ethel had an anomalous blood vessel to her kidney. But just in general, just kind of briefly, if the how would one know or find out that you're getting poor blood flow to your bowels or your kidneys?
Well, one of the more frequent situations that we see. Now let me say from the outset that the blockages we're talking about can occur in any of the peripheral arterial beds that you have. So arteries going to your intestine, arteries going to your kidney, arteries going to the lower extremities, arteries going to your pelvic organs, etc. They can all harbor these blockages. And if you have a significant blockage, let's just say you have a significant blockage to an artery or within an artery that's going to the kidney, and that kidney's not getting enough blood flow, then one of the ways that you might find that out would be through your family physician who says, hey, your kidney function is off a little bit on our routine testing that we did, and we're going to look into that a little more with probably an ultrasound examination.
Okay.
And then on the ultrasound, lo and behold, a blockage shows up. So when I was in training, we did all those operations open with a bypass. We very quickly transitioned in the late 1990s to fixing a lot of those blockages with balloon angioplasty with a stent, usually, unless it was something rare. But almost always we would leave a stent behind. And we did that for an awful lot of patients. And the thinking was we know that that artery is intimately involved in the control of blood pressure. And so we can better control blood pressure if we don't have a blockage in the kidney artery. And we can keep those patients from going on to develop renal failure. Now, there are several studies that were done, controversial, but certainly a lot of people use those studies. And one was the Coral study, and I can't remember the name of the other study offhand, but they both came out at the same time. They're about 10 years old now, and they radically changed the face of how we treat blockages in the kidney arteries. And it turns out, and I do believe this is very controversial, but I believe that we were way too aggressive in treating a lot of the kidney lesions. And so we don't treat near the number of kidney, or we call them renal artery stenosis, RAS. We don't treat near the number that we used to because we were probably over treating a lot. And it turns out that a lot of those can be treated medically, especially with our new medications to control blood pressure, the so-called ACE inhibitors and the so-called ARBs is another big class. So, but we do still treat a lot of blockages that go to the intestines.
Yes, tell me about that.
That usually presents in patients who are very avid smokers. They've lost a lot of weight recently, and they have abdominal pain after they eat. So going back to that whole discussion we had about claudication, when you exercise the muscle group and it doesn't get enough oxygen delivered to it because of a fixed problem in the artery, you can develop a cramp. Well, the same thing can happen in the intestine.
You get a claudication of your guts.
Yes.
Unbelievable. That makes sense.
It's actually called postprandial
after you eat.
Yeah, postprandial abdominal pain, postprandial angina.
So you diagnose that. So what can you do about that?
We can actually, once we define where it is, we almost always use stents to correct that problem. And again, a stent is a metal scaffolding that we're going to use to push that blockage to the side to reestablish a good flow channel there.
And it's effective and it works.
Very, very effective.
Tremendous.
And risk profile very low and way better than some of the other things that we still do sometimes, but rarely, which is where we go in with an open operation and we do a bypass of an intestinal artery or a clean out of an intestinal artery or remove some acute problem like a blood clot in an intestinal artery. And let me also, while we're talking about that, and we're talking and kind of getting back to the blood clot, I meant to say this earlier and I didn't. COVID, as you probably know, is a virus which is very substantially correlated, or I should say maybe strongly correlated with the inducement of blood clots.
Yes. Yes.
And it's
Fibers,
not
really
just
bad blood clots.
yeah, and not just lower extremity deep vein blood clots, but we see blood clots in the upper extremities. We see blood clots um, in and around the heart, and we see blood clots in and around the intestines and so forth. So
More often after COVID infection.
yes. So since
Coronavirus.
2019, we have seen just a huge increase in the number of patients that we evaluate for what we think and what we know in some cases, but we think in a lot of cases are COVID-induced hypercoagulable syndromes or blood clots associated with COVID.
A whole new world of
Yeah.
COVID, long COVID, things you think of it as a pneumonia, but it's much, much more complicated than that.
Yes.
Wow. So
Yes.
working our way up the body, we've got so much more to cover. Dr. Adams, I believe something that you deal with frequently are atherosclerosis, are plaques in the carotid arteries
Yes, we do.
going to
We
the
do.
brain. Now, why
Yeah.
are those called endarterectomies? Why aren't they called carotid atherectomy? So we could tell me about the name. Why is that? How common is it, and what can you do about it?
Okay, so carotid atherosclerosis of the major internal carotid artery is something that's been described for a long, long time, and I'm not going to bore you with all the history of it, but I will tell you that when we see patients who present with a symptomatic lesion of the carotid artery that has caused a stroke,
Okay.
or maybe and a stroke is defined as a neurologic deficit that persists beyond 24 hours, or maybe a mini stroke or a transient ischemic attack, a TIA, which is
Okay.
less than 24-hour duration of a neurologic problem. When we see that and we have a very significant blockage or lesion in the carotid artery, then we know more oftentimes than not that the risks are going to be less if we can go in and clean that blockage out than if we don't do anything and just treat that patient medically. Now, it's a huge oversimplification. I have probably 4 textbooks on my shelf that are just about the carotid artery.
Wow.
So it's really one of those things that it's a lifelong learning process. And since I've been in vascular surgery, this is my 28th year. I've seen a dramatic change in the way that we treat patients. For example, asymptomatic carotid lesions, even up to 70%, 75%. We're by and large treating those conservatively with medical management now rather than surgery or stents.
Okay.
If you're symptomatic, if you've had a little mini stroke or a stroke,
Right.
and you have a significant blockage, and significant in my mind would be 60, 70, 80%, then we're going to either put a stent in that or clean that out. And again, huge oversimplification, but it's one of those things that we could talk for days about this and still not even scratch the surface.
It's a big subject, and it seems that that's one of the hot spots. You mentioned there's certain areas of the body that tend to make these plaques.
Yes,
and it's a hot spot for some reason.
it is the very start of the carotid, the internal carotid artery that goes up to the brain, is what's called the carotid bulb, and it's a little dilated area of the artery, and it's the posterior lateral surface that tends to accumulate plaque. And the reason for that is probably because there's normally a reversal of flow there, and that reversal of flow exerts a hemodynamic injury to the endothelium.
A turbulent is rubbing it.
Yes,
it's rubbing
the
it with a turbulent
flow, and it allows the migration of LDL across that injured endothelium, which becomes oxidized and leads to this whole process that we deem atherosclerosis. Atherosclerosis is really an inflammatory process. I think pretty much everybody agrees on that. And it's due to the oxidation of the LDL. And it tends to happen right there in the carotid bulb because of the physical properties of that area and because of a lot of the hemodynamic properties in the face of hypertension, in the face of high cholesterol levels, nicotine, things like that.
or homocysteine, and I'm gonna push back on the
Yes,
cholesterol
yeah, I don't want to get
and
into that.
and intimal thickening and migration of macrophages that it might be more important than the cholesterol
You're
itself. And anyway, so once again, huge topic. But what I'm interested in is how do you go in there, Johnny? Peel out this eggshell crunchy stuff, get it out, and then put it back together. And I just imagine all these crumbly pieces. Once you do it, all of them just you open up the artery and it just goes up to the brain and strokes out the brain. How can you do it so cleanly and effectively that you're not showering the brain with more of these?
well,
Because atherosclerosis people need to realize these plaques are like crunchy eggshells.
they come in all different varieties, from crunchy
Ah,
eggshells to cottage cheese consistency, et cetera, et cetera.
toothpaste. I've seen toothpaste.
So almost always when we are working on the carotid artery, we have it clamped so that there's no flow going to the brain through the part we're working on to flush those particles up to the
It
brain.
seems that clamping would break
Aha.
off pieces.
That's very good. So we use a shunt. A lot of times we will use a shunt around that area to maintain flow to the brain while we're working on that artery.
So you can plug in one side and the other,
Yes.
and
Yes.
temporarily bypass that spot.
And
Ah,
there are times where we don't use a shunt because we know that the collateral blood flow in the brain through a system that's called the circle of Willis.
the blood
and
flow from the other side is enough to keep the brain alive while you're working there.
the back and the other side, yes. And we're able to measure certain factors before we clamp. We're able to measure certain pressure points and determine, is it adequate or is it not adequate? And if it's not adequate, we're probably going to use a shunt. If it's adequate, then we probably do not need to use a
You've got
shunt.
time to do your work.
Yes. There are surgeons who, if you're going to do this open carotid surgery, they will use a shunt all the time. There are surgeons who will selectively shunt. And then there are surgeons who, I don't ever shunt, I just do it really fast.
Real fast. And
Yeah,
they're good
yeah,
at that.
yeah.
And they can do that.
And those are the open operations. If we're doing a stent, then almost always we will have a protection device to keep the little particles from going to the brain. And that could be an umbrella filter placed up high.
And
So
does that stay there forever or just during the case?
Just during the case.
Okay.
We take that out at the end of the case. Or we can reverse the blood flow so that the blood flow is not going up to the brain, but it's actually being reversed into a little protection device.
And you're washing out those pieces.
Yes.
There you go. Because that always bothered me. How could you do that without creating strokes? Clearly, you have methods for doing that. Fast. So you do a number of those. That's a fairly common procedure for you, isn't it?
It is very common to do a carotid endarterectomy. And endarterectomy means taking out the inner lining of the artery.
Ah, okay.
The artery is made up of 3 different layers, and we take out usually the intima and the media where the plaque resides.
Okay.
The adventitia is the outermost layer, and fortunately for us, it's the strongest layer, so we can take out the inner 2 layers without compromising the strength of the artery.
Now, how come clots don't form over this rough surface that you've created?
Well, we use a blood thinner during surgery to prevent that, and then usually after surgery, we will use a platelet inhibitor like aspirin or like Plavix or like something like that to try to keep that from happening. But the other answer to your question is we try as best we can to make sure we have a smooth surface and we do not have many irregularities there, many if any, so that the flow is nice and smooth and laminar and is not turbulent in any way.
You've got to be, what's the size of the suture? Now, this is kind of esoteric. Your sutures are getting small when they get down to 6, 7, 6.
Yeah, we use 6.0
6.0.
and 7.0 for the carotid.
You're getting down to close to hair, to several times bigger than a human hair at that point. And then you're using very smooth sutures called Proline, I believe. Right?
Yes. We use a monofilament Proline suture, and blood elements stick to that much less so than, say, a braided suture, and that's why we're using the monofilament. We use what's called loops, And loupes are glasses that have little telescopes on them.
So you're doing this under magnification?
2.5 magnification minimum, sometimes 3.5. And that helps remarkably. The sutures really need to be placed in a precise fashion, and that's what your 5 years of general surgery and your 2 years of vascular surgery is all about. And then obviously the learning that goes on continually once you're out in practice.
This is why having an experienced vascular surgeon is so important. So important. Who's good? Who's good? Now, we've talked about a lot of stuff here. Let's just briefly touch on a couple more things that you do. If a person is having clots in their legs and they want to, and they're maybe have thrown some. I mean, throwing meaning they migrate up to the heart and the lungs. If they're going to be doing this more often, what is this filter you can put in the vena cava that I hear so much about?
Well, an inferior vena cava filter looks just like a shuttlecock that you would play badminton with. And a guy named Lazar Greenfield, while he was a medical student at the University of Oklahoma, developed this thing.
As a student, I love it.
Yeah, it was actually phenomenal that he did this. But so we can go in. Let's say we have a patient and they are having recurrent blood clots, and parts of those blood clots are breaking off and going to the heart or to the lungs. And we're not having success treating them with our traditional anticoagulation or blood thinners, or maybe they can't take blood thinners because they have other problems such as bleeding coming from the GI tract or the urologic tract or something like that. So if they have a contraindication to a blood thinner, or we're just not successful with blood thinners, we can put in one of these shuttlecocks, if you will, or a filter. And we can
it's
do
called
that.
a Greenfield. It was his name Greenfield?
Greenfield, his name was Lazar Greenfield. He was
Okay.
the initial guy. So all the filters initially, when I was in training, were Greenfield filters. Now we have a lot more variety of filters and so forth. And I would say that most of the filters that are probably put in today are not the Greenfield variety. And the reason for that is it has a lot to do. You can remove a Greenfield filter if you really have to, but we have filters that are way easier to remove. So nowadays we would go in, we would place a filter in the inferior vena cava.
That's for everybody, that's the big vein that's draining your whole lower body and feeding the heart. Okay.
Exactly.
Okay.
So we put the filter there to catch the blood clots. And these filters are designed so that they will catch blood clots that are deemed significant in size. And for every filter, that's a little different, but they catch very small blood clots. And then the blood that goes by that will actually lyse that blood clot over time.
So it'll dissolve.
So it will dissolve over time.
I was wondering what happens. Now you got a big clot, filling up your vena cava, a big chunk of blockage there, but it does melt.
And usually it melts away with time. In fact, that's one of the risks of having a filter, which is you get a big blood clot there, it could block off all the blood flow and you would develop massive swelling of the legs. Happens about 1% of the time with the filter, so it's very low. So yeah, we put in Greenfield. There I am again. We put in filters, inferior vena cava filters. And I would say these days, maybe not the majority of the time, but a significant number of filters we go back and we remove, and we can do that again under X-ray. So it's a little ballpoint pen stick, either down in the groin area in the femoral vein or up in the neck in the jugular vein. And we usually do it with the patient heavily sedated or under a general anesthetic, because we want to be extremely precise in where we put it, control the breathing, etc.
I can imagine if something breaks off or goes in the wrong direction, or you've got a piece of metal floating around in there. Oh my goodness.
That's called a very bad day.
It's called a very bad day. So Johnny, we've talked about a lot of stuff, and I believe we've covered most of the things you do day to day. Let's talk briefly about people on kidney dialysis and they need access to their blood. Okay? The kidneys filter the blood, take out waste products. That can be done with a machine. Now, for a person on dialysis, they're doing this typically twice a week, and they have to have these big IVs put in there 3 times a week. Oh my goodness. And you need access to their blood over and over and over. One of the procedures I believe vascular surgeons like you do are things called fistulas, AV or arterial venous fistulas, where you've taken a vessel or a tube and connected a big artery to a vein, usually in the arm, I believe, and that allows them to get blood out and put the cleaned up blood back in the body, right?
Yes, absolutely.
So tell me about these AV fistulas that you create.
Well, unfortunately, in this country, we have a lot of patients who develop kidney failure, and the two primary reasons are high blood pressure, hypertension, and diabetes. And so in that population of patients, there are really three main ways for you to continue on and to receive a therapy that takes the place of your kidneys. And those therapies are just what you were talking about, which are called hemodialysis access options. And I'm gonna come back to that. And then you can also put a catheter in the tummy. It's called peritoneal dialysis. We're not going to get into that really, but and then you can get a kidney transplant. But for most people in this country, they're going to be on a hemodialysis option. And you're right, that's where we connect an artery to a vein, or we put in some type of synthetic graft as a substitute for a vein. And what we're doing is we're creating a high flow circuit from the arterial to the venous system. And that allows the dialysis units, and we have many, many here in central Missouri, it allows the dialysis units to access that circuit with 2 needles, one to withdraw blood. It goes through a kidney machine that cleanses the blood, and then it's delivered back to the patient through the other needle. And a typical treatment will take about 3 hours. They need 3 treatments per week to do the work of the kidneys. It's not a perfect treatment because you're doing the work of the kidneys over 48 hours. You're now cramming that into 3 hours.
Yeah.
And so if you'll remember, the kidneys take a lot of fluid off of us each day. And so we're taking off fluid in 3 hours that would normally be taken off in 48 hours. So it's tough on patients, but we do an awful lot of that. We call those accesses the patient's lifeline. And as a matter of fact, if something goes wrong with that lifeline, then it's an urgent situation for patients. Now, it's funny you bring that up because as I was coming in here today, one of my partners on call called me. There are literally, she's had 3 consults today for that exact thing. And so
to put one in or to fix one that's clotted up that needs to be redone.
3 that need to be redone that are clotted, and that may mean going in and removing the blood clot with either a catheter, what we call a percutaneous, or an open technique, or it may mean modifying the lifeline, or it may even mean putting in a new lifeline. So and then there are times where we temporize patients. We can't get any of those things going in a timely manner, so we put a catheter in. And through the catheter, the patient can receive a dialysis treatment while we're trying to plan.
A big vein somewhere else, maybe
yes,
in the neck
a big
or
vein in the neck, the jugular vein or the subclavian vein, typically, while we're trying to figure out what our options are. Where are we going to put a new access?
Because it seems those keep you very busy.
It is. It's you know, the primary thing. Well, first of all, the thing that led me to vascular is the diversity. You just get to do so many different.
I've just done the whole body with you here.
And I'm going to be honest with you. Yeah. There are many things that we're not going to talk about that I just love to do. And so for a typical month, I probably would do, I'm going to say 50 different operations, maybe 75 different operations. And it's just so fun to do that. Yeah. We're not doing the same thing over and over and over. We use a lot of the same techniques. There's no question about that. But as far as the operations go and trying to fit that to the patient and so forth, that's just such a challenge and such a great feeling.
Yeah. Wow. Now, can you think of any instances? I'm looking for something off the beaten path. weirdest thing you've ever seen in vascular surgery? Like somebody, like I've heard stories about somebody's had a dead toe and it's just been dead for weeks and weeks or months and months. Or what's the weirdest thing you've ever seen in vascular surgery practice?
Well, gosh,
It's a small world. We can change names.
Yeah. Only about 20 things come to mind immediately. But
tell me 2 or 3, please.
When I was a medical student, I was a second year, and we had a class called Introduction to Clinical Medicine. And that Introduction to Clinical Medicine was all about how to do a history correctly and how to do a physical exam correctly. And so you would get a second or third year medicine resident. And you got to remember, this is at UT Southwestern. So Parkland, the big city hospital in Dallas, just an incredible place, and a wealth of teaching opportunities, if you will, in that hospital. And so what we would do is the resident would spend probably 5 to 10 hours with each of us, showing us the different aspects of how to elicit a history and how to do an exam. And then he would take us over to the hospital, and he would have picked out a patient, and he wouldn't tell you anything about the patient. You would go in, and you would spend a couple of hours with the patient trying to figure out exactly what's wrong. So you weren't supposed to get in the chart or anything like that. And while you were doing that, the resident would stand in the hallway, and he would listen to you. And there would be times he would kind of peek in and so forth. And the families and the patients knew that, hey, these were students and they're learning, and would you consent to this? And, do you have any problem with it? Da, da, da. And almost everybody would consent to it, because it was that type of atmosphere where everybody was just really interested in doing anything they could to advance medicine. So I had this resident, and he taught me all the finer points of the history and the physical exam. And so I went over, and I'm interviewing this patient, and I get through the history, and I'm doing the physical exam. And so I pull my stethoscope out, and I do exactly as my resident had taught me to do. I take the stethoscope, and I put it on top of the head to listen for any abnormal sounds in this one area over the cranium that you can hear inside the cranium. Now, you got to understand that hardly anybody ever does. In fact, I've never met another person that does this, but
Right.
he felt very strongly about this. So I pull my stethoscope out, and I place it on top of this lady's head who was in her 60s and was there for a totally different reason than anything having to do with her brain. And her daughter is sitting there, and she'd been intently listening to this whole thing with the history and was really into this. And she turned to her sister who was next to her, and she said, I'll never forget this. I was so embarrassed. She said, "You can tell he's a student. He doesn't even know where the heart is." and even my resident was laughing a little bit, and I was so embarrassed. I didn't know what
great.
to do. So anyway.
That's
But
great.
vascular, it comes with a lot of work and a lot of satisfaction, and we do have times where it's hard to actually believe exactly what we're seeing. And I got to tell you one other one, if
Please,
I have time.
I want to hear. I want to hear another story. Please.
Okay, so I got called from the emergency department by one of my orthopedic surgery colleagues, and this has been 5 to 7 years ago now. And he said, "Hey, Johnny," he said, "you think you could come in and take a look at this?" And I said, "Well, what's going on?" And he said, "Well," he said, "I got this young guy here, and he said, you just got to see this. You're not going to believe it." He said, "We're going to have to go to surgery tonight." And he said, "I really need your help." I said, "Okay, I'll be right there." Had no idea what was going on. Great friend of mine, great surgeon. And if he said, "Hey, we're going to have to take this patient to surgery," then, okay, well, that meant, he needs me and pretty quick. So I go in, and by the time I get there, he already had the patient in the room. And so
In the operating room?
In the operating room.
Okay.
And this was like within 15 minutes, 15, 20 minutes. And I'm like, holy cow. So we're outside the room, and he comes out and he says, "Hey," he says, this guy is a carpenter, and he's a framer." And he said, "I don't know if you know anything about framers." And I said, "Well, a little bit." And he said, "Well," he goes, "those automatic nail guns they use?"
Uh-oh.
I go, "Yeah." He goes, Well, he was resting his nail gun on his leg, and he put a nail through his leg, and not just any nail. This is a nail,
Big ass nail.
big nail. And I go, okay. So they put him to sleep. They roll him over into the prone position, so face down. And so then I go in with this orthopedic surgeon, and we're looking at this nail that is in the popliteal fossa, so behind the knee, and there's only about an inch sticking out. And immediately I said, is anything coming out the front? Is there anything coming out of his patella? And he goes, no. He goes, this nail is coming right to the surface of the patella, but it didn't, as best I can tell, it didn't penetrate the patella. He said, but I'm worried it's right through the artery or the vein.
Yes, that's
And
the pop.
I said, okay. So we operate on this guy and made a little 2-inch incision and exposed everything. And this nail, you got to understand, the artery and the vein in that circumstance are intimately together. There's just no way. There's no way to get anything between them. And this nail went right between them and did not injure either one of them. So we were able to remove the nail, did not have to put one suture in anything, closed the soft tissue, obviously cleaned everything up, closed the soft tissue, took the fellow to the recovery room, and I'm sitting in the lounge dictating a note when the orthopedic surgeon walks in and he goes, hey, you're not going to believe this. I said, what else?
What else?
And he goes, a guy just got up out of recovery room and left. I said, what do you mean? He goes, he just got up and left. He goes, we have his name and everything, but he just left. He just left against medical advice. He just walked out. I'm like, holy cow. So anyway, so that was never saw the guy again. I'm sure he did great. I hope he did great, but never heard one more word about him.
What a story. There's something they say and I hope I don't piss off my friends at the VA. They deal with tough old coots, old grizzled war veterans. They say, sometimes these guys, you just can't save them. And sometimes, Johnny, you just can't kill them.
Well,
they're tough as nails. So that guy was tough as nails.
Tough as nails.
He took the claw hammer, pulled it out, and he walked out on you.
Well, not exactly a claw hammer.
Didn't write.
Yeah, we did pull it out.
Well, Johnny, thank you so much for the stories. Thank you for a very insightful, delightful conversation. I learned a lot, and I hope our listeners will also learn a lot from your expertise and know when now to go see a vascular surgeon for any of these problems we've identified.
Well, I want to tell you, it's really a pleasure to be here. I've really enjoyed this, and I've always enjoyed our friendship and collegial interactions and so forth. So I just had a ball. I've enjoyed it.
Thank you so much for coming, John.
Absolutely. Thank you, Gil.
Thank you, my friend.
Yes, sir.